Hello, everyone. Before I begin, I'll share just a couple of procedural things. You'll notice that the chat function has been disabled. However, throughout the presentation, you have access to the Q&A to pose questions to our speaker and also reach out to myself and Jason, who are here on the back end, to answer any technical questions you might have. We will also carve out plenty of time at the end of Nikki's presentation to discuss any questions that you put into the Q&A. You'll also see that there's a survey at the end of the webinar. It will be on your screen in a Q&A, as well as posted as links in the chat. We will also send that survey out to you via email after the webinar concludes. Please take just a couple minutes to fill in the survey and let us know what you liked and what you'd like to see in future webinars. You'll also notice that this webinar is being recorded and will be posted to Ava's YouTube channel shortly. This means you can revisit this webinar and share it, as well as any of our previous webinars. After I'm done with the introduction, I'll post the link in the chat so you can access that, or our YouTube. Without further ado, welcome to the Alliance Against Violence in Universities Webinar Wednesdays. I'm your host, Dr. Sarah Yursich. With Ava, I'm an early career researcher and lead on the webinar series. Outside of that role, I'm the co-director of the Frida Center for Research on Violence Against Women and Children, housed in the School of Criminology at Simon Fraser University. I'm also a full-time instructor at Capilano University in our Department of Criminology. I'm joining you today from the unceded, traditional, and ancestral territories of the Coquitlam First Nation. And on behalf of AVA, I want to begin by acknowledging that, on a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous peoples of the lands on which they live, work, or visit, and become engaged allies together. We, as Canadians, in the spirit of truth and reconciliation, respect the self-determination of First Nations, Métis, and Inuit peoples, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. The focus of today's webinar is Advancing Domestic Violence Education in Healthcare, featuring Nikki Smith from Recovery, Alberta. Nikki is a clinical consultant and nurse educator with over 18 years' experience across emergency, mental health, forensic, and acute care settings. She has held roles in Alberta's domestic abuse response team, sexual assault response teams, as well as with the University of Calgary, with expertise in domestic violence, forensic nursing, curriculum development, and implementation science. Nikki, thank you so much for joining us today. I'm so excited for your webinar.
Thank you, Sarah, for having me. I'm really excited to be here. So good afternoon, everybody, and thank you again, Sarah and Jason and the AVA organization for the opportunity to present today. As Jason so kindly introduced, my name is Nicole Smith, and Sarah introduced, and I'm a registered nurse with over 18 years of clinical experience in Alberta's healthcare system. My particular area, as Sarah indicated, is on sexual and domestic violence. So I've been invited to speak today about domestic violence and how it remains a significant health issue with substantial physical, psychological, and social consequences for our individuals, families, and communities in Alberta. And given that healthcare settings are often one of the very few systems with which individuals experience violence have ongoing contact, our healthcare providers are uniquely positioned to identify risk, respond appropriately, and facilitate access to this support. So in this presentation today, we're going to examine the role of the healthcare provider education as a strategy for strengthening the healthcare response to domestic violence. And specifically, I'm going to discuss the evolution of our Alberta Domestic Abuse Response Team, or you'll otherwise hear me refer to it as the DART program, into the province-wide educational initiative. We're also going to talk about the rational underpinning for this approach and then the outcomes observed following our implementation. So the objectives for today are to discuss the rationale for domestic violence education in healthcare and why healthcare settings represent a critical point for identification and intervention. I'm then going to review the evolution of our Alberta DART program, and I'm going to focus on the transition from a direct service model to a province-wide educational strategy. We're also going to look at the overview of the domestic violence electronic learning curriculum, and we're going to include its structure and the target audience being our healthcare providers. And so for the purposes of today's presentation, I want to just say that the definition of healthcare providers are going to be the employees under the healthcare system. And then we're going to talk about their intended learning outcomes from this education. The presentation is also going to examine key clinical considerations in domestic violence care, including our approaches to screening, barriers to disclosure, and the importance of trauma and violence-informed practice. And then we're going to close with a discussion on several system-level factors that influence healthcare provider readiness and the sustainability of the educational initiatives within our healthcare organization. So to understand the rationale for domestic violence education within healthcare, it's important to consider how domestic violence has traditionally been conceptualized. Historically, domestic violence has often been viewed primarily as a social services or criminal justice issue. And while these systems play essential roles in responding and intervention, this perspective can overlook the significant role of healthcare settings in identifying and supporting individuals experiencing violence. In practice, many individuals affected by domestic violence have repeated interactions with the healthcare system, often before engaging with law enforcement, shelters, or other community-based services. These encounters occur in our emergency departments, primary care settings, inpatient units, or other points of healthcare, and frequently take place without direct disclosure of violence. So when we think about it, it really positions healthcare providers as a critical participant in the broader response to domestic violence. And as a result, the relevant question is not whether healthcare should be involved, but whether providers have the knowledge, the skills, and the confidence necessary to recognize indicators of abuse and respond effectively when those opportunities for intervention arise. So if healthcare is a critical setting for identification and response, the next question is why? And the answer lies in both the prevalence of domestic violence and the limitations to other systems consistently meeting the needs of the individuals experiencing domestic violence. The importance of healthcare involvement becomes clearer when we consider this within that broader context of prevalence and the service utilization. So as we all know, domestic and intimate partner violence are widespread public health concerns. In Canada, approximately 1 in 2 women will experience physical or sexual violence during their lifetime, yet only a minority of these incidents are ever reported to law enforcement. At the same time, community-based resources, including emergency shelters and support services, often operate at or beyond their capacity, limiting that timely access to safety and intervention supports for many of these individuals. So consequently, healthcare settings frequently serve as one of the most accessible and consistently available points of contact for individuals experiencing violence. Patients present repeatedly for care related to physical injuries, chronic health conditions, mental health conditions, or other violent-related impacts, and this is often without explicitly disclosing abuse. The reality is particularly important given that intimate partner violence can escalate over time, increase the risk of serious injury, long-term health consequences, and in worst-case scenarios, homicide. So when we take these factors together, position healthcare not as a peripheral component of the response system, but as a critical setting for early identification, intervention, and connection to support services for healthcare providers. Okay, so healthcare settings then provide a unique opportunity for identification and intervention. So through routine assessment, clinical inquiry, and patient-centered care, providers can recognize indicators of violence and offer immediate support and facilitate connections to resources such as social work, advocacy services, and community-based programs. Importantly, these interactions can occur within a safe and supportive environment at a time when other avenues of assistance may be limited. So this role is particularly significant because early identification and intervention have the potential to alter trajectories of harm. Timely recognition can reduce the risk of injury escalation, improve access to support services, and contribute to better health and safety outcomes for our individuals experiencing violence. Understanding these systemic realities also has an important implication for our clinical practice. It encourages healthcare providers to approach patients with greater empathy, patience, and awareness of the complex barriers that influence a disclosure. So healthcare becomes a place that plants that seed of trust, creating a safe space where patients feel comfortable so that they can return for care. So, when criminal justice and social service systems are inaccessible, or they might be delayed or unable to respond to immediate needs, we know that individuals experiencing domestic violence will present within a healthcare setting. And so, this positions our healthcare providers as a consistent and often trusted point of contact within that broader response system. And unlike many community based services, healthcare encounters remain accessible regardless of an individual's readiness to disclose abuse or engage with those formal supports. In addition to understanding that system level risk factor, we help healthcare providers recognize that both risk exposure and opportunities for disclosure are shaped by social and environmental contexts. So, risk is not experienced uniformly. Rather, it is influenced by the settings in which that individual lives, works, and seeks care. So, in rural and remote communities, several factors can create these additional barriers to disclosure and help seeking. So, we start with limited anonymity. In small communities, individuals are highly visible and interconnected. So, there's increasing concerns about privacy and confidentiality. There's geographic isolation and limited service access. So, specialized supports, including shelters, advocacy services, and law enforcement resources, may be located significant distances away. And accessing these services requires long distance travel, transportation, and resources that might not be readily available during a time of crisis. And finally, there's the overlapping social and professional relationships. So, individuals experiencing domestic violence may personally know healthcare providers, law enforcement personnel, or other service providers within their community. And these intersecting relationships can create concerns related to stigma, judgment, confidentiality, or the potential consequences for family members and partners, making disclosures a lot more difficult. So, as a result, decisions regarding disclosure are often influenced less by the individual's willingness to seek help and more by their assessment of personal safety, privacy, and the potential of consequences for disclosure. And so, understanding these contextual factors is essential for healthcare providers as it supports a more nuanced and trauma informed approach to assessment, intervention, and that patient engagement piece. So, the influence of context, of course, extends beyond geography and requires a standardized approach to screening and connection to resources. And a range of social and cultural and structural factors can also affect both the individual's risk of experiencing violence and their ability to safely disclose or access support. So, several populations experiencing unique vulnerabilities and barriers that require tailored and trauma and violence informed responses are our Indigenous peoples, where there's ongoing impacts of colonization, intergenerational trauma, and the need for culturally safe care. Our 2S LGBTQIA plus individuals, where there's concerns related to discrimination, stigma, and not being believed when seeking support. Our children and youth, where there's developmental considerations, dependency relationships, and mandatory reporting obligations. Our individuals with disabilities, where there's reliance on caregivers, communication barriers, and considerations related to autonomy, capacity, and consent. Our older adult populations, where there's risk associated with cognitive impairment, social isolation, and elder abuse. Our newcomers and migrant workers, where there are language barriers, immigration related concerns, social isolation, and that vulnerability to exploitation. Our individuals who are unhoused or substance use disorders, where we have complex social needs to consider, competing safety priorities, and the importance of harm reduction approaches. Our men and boys, where there's still social stigma, gender norms, and lower rates of disclosure and help seeking because of the social stigma. Our individuals experiencing intimate partner violence, where we have our ongoing safety concerns to consider, coercive control, stalking, and risks associated with separation on returning home. Pregnant and postpartum individuals, where there's that vulnerability to violence and potential impacts on both the parent and infant. And of course, our victims of human trafficking, where there's high levels of control, dependency, and significant barriers to identification and disclosure. More importantly, these populations should not be simply viewed as demographic categories. Rather, they represent contexts in which social, structural, and systemic factors influence the vulnerability, access to services, and the capacity to safely disclose experiences of violence. So, for healthcare professionals, understanding these intersecting factors is essential to delivering equitable trauma and violence informed care. So, given the prevalence of domestic violence, its uneven distribution across our populations, and the systemic and contextual factors that shape the disclosure and access to care, the DART program was really confronted with a central implementation challenge. And that was how to meaningfully influence our healthcare providers' practice at a scale within these existing system constraints. And in response, education emerged as the primary intervention strategy to strengthen the provider capacity, improve recognition and response, and support more consistent application of domestic violence informed care across our clinical settings. So, a bit of the background is the transition that reflects the broader reorientation in our strategy. And so, this was shifting from a service delivery model to centered on direct clinical intervention towards a system level approach focused on capacity building through education. So, rather than situating domestic violence response primarily within a specialized team, the emphasis expanded to include all healthcare providers as active participants in their identification, response, and initial intervention within their respective scopes of practice. In this particular framework, our education becomes the primary mechanism for strengthening our clinical readiness and supporting more consistent application of domestic violence informed care across all healthcare settings. The DART program itself originally operated as a provincially funded service delivery model. It provided 24/7 specialized domestic violence response through a collaboration between our Alberta Healthcare Services and community-based agencies. However, as the program evolved, a consistent system level gap became quite evident. The primary limitation was not the absence of a service, but the variability in provider readiness across our healthcare systems. And as a result, even when referral pathways and our specialized supports were available, identification and engagement processes were inconsistently applied. I like to give the example here of between 2021 and 2022, we hosted more than 67 education sessions to healthcare providers. And the feedback from these sessions reinforced that clear need for scalable, accessible, workflow integrated education. The feedback itself marked that pivotal shift in program direction. So, from expanding a service model to developing education as a system infrastructure. So, when DART went to work to provide this sustainable education based off of the feedback, we also were presented with another key challenge as healthcare education is balancing competing training demands. So, healthcare providers are also working shift based schedules and often balancing multiple mandatory training requirements annually. And in recognizing these competing demands, DART sought an approach that would build the confidence in domestic violence screening and resource connection without adding an unnecessary burden. So as a result, we transitioned to an asynchronous didactic e-learning delivery through our My Learning link and our Clinical Learning and Improvement Collaborative link, which is CLIck. These are provincial learning and improvement networks that help ensure healthcare providers across Alberta are practicing consistently, safely, and in line with current evidence. These e-learning platforms allow 24/7 access, self-paced learning, consistent delivery across regions, and because of this, helps reinforce the education over time. So the shift here is really important. It's not simply a change in format, but a change in educational sustainability. So let's look at the modules themselves. The modules were designed using a structured learning progression. Module 1 establishes foundational knowledge. Definitions for domestic violence are included, and these definitions are, but not limited to, family violence, sexual violence, intimate partner violence, coercive control, spiritual, religious, and psychological violence. We talk about the prevalence of domestic violence, the legislation and the legal context, disclosures to barriers, and our universal screening principles. Once healthcare providers have completed module number 1, they are welcome to take module 2 or 3. In module 2, it focuses on more of the inpatient and outpatient application process. So here we really look at the clinical integration, documentation workflows, interactive simulations so that healthcare providers can apply what they've learned in both the modules. And then finally, in module 3, we focus more so on the emergency and urgent care environments. So we look at the high-risk identification factors. This includes things like strangulation and traumatic brain injury and those rapid intervention strategies. I want to point out that across all of these modules, the goal is consistency of design and repetition of clinical decision pathways. These modules are intentionally designed for the adult learner in clinical environments. And we do this by incorporating scenario-based learning, interactive decision points, audio simulations of patient-provider interactions, survivor and expert perspectives, and repeated knowledge reinforcement. The goal is not passive acquisition. The goal is knowledge translation leading to that applied clinical readiness. So ultimately, clinical readiness is demonstrated not only by recognizing domestic violence, but by creating the conditions that allow patients to safely disclose when they are ready. So in training healthcare providers to identify, assess, and support patients experiencing domestic violence, we help them understand that disclosures of domestic violence is often a gradual process rather than a singular event. And we know this because research demonstrates that patients are more likely to disclose when they are experiencing trusting relationships, continuity of care, and non-judgmental supportive interactions with healthcare providers. And this evidence really underpins one of the core principles of the education, which is our universal screening. So rather than relying on assumptions or visible indicators of abuse, which are most often not there, providers are encouraged to ask all patients about domestic violence in a private setting and when they are alone. And this standardized approach really helps reduce bias, minimizes missed opportunities for identification, and promotes equitable care. I also want to point out that we use a professional interpreter service, which is called our language line. And this emphasizes to ensure privacy and accuracy and patient safety, rather than relying on family members that can induce miscommunication. So structured language is provided to support our clinicians in initiating and navigating these conversations so there isn't any miscommunication. And again, the goal is not to force the disclosure, but to create a safe, consistent opportunity for it. So to achieve this goal, the education needs to reach the healthcare providers who are responsible for delivering care. And so now this brings us to the implementation part of the program and its uptake across the province. Since the launch of our domestic violence electronic learning modules in July of 2025, we have had over 5,200 healthcare providers across the province complete this training. The demographic data that I have in the table shown on this slide is generated from our My Learning Link analytics, and they track our monthly module completement. And so this report is provided to our DART team to monitor uptake and understand which professional groups are engaging with the training. The participants have included a broad range of healthcare professionals across inpatient, outpatient, and our emergency settings. This includes our physicians, residents, medical students, nurses, which are our RNs, our LPNs, our psychiatric nurses, allied health professionals who are our occupational and physical therapists, psychologists, psychiatrists, social workers, child specialists, and healthcare administrators, just to name a few. I also want to point out that upon completion of these modules, participants are also offered a voluntary option to wear a button we created indicating that they are trained and a supportive resource for individuals experiencing domestic violence. And this symbol really serves as a visible commitment to creating safe spaces for disclosure and reinforces the importance of recognizing, responding to, and supporting patients affected by domestic violence in a trauma and violence-informed manner. So what has been the feedback since the launch of these modules in July of 2025? Well, based off of our REDCap surveys that are provided at the end of each module, we were able to obtain the following data. So from a total of 605 participant feedback surveys, approximately 90% reported increased confidence in safety initiating these conversations around domestic violence, while 88% felt better prepared to respond appropriately to disclosures, and they intended to integrate learning into clinical professional practice. So from a practice perspective, these findings have had several implications. Increased provider confidence and preparedness may strengthen early identification of domestic violence, improve the consistency of clinical responses, and enhance the capacity of healthcare providers to deliver timely and trauma-informed care. It is important to note that this is not an academic research study and that the data collected to date are based solely on our post-module self-reported survey responses. And while these findings provide valuable program level feedback, I well admit they are limited in scope and analytical rigor. However, they do offer direction for future work. The results suggest the opportunity for further academic research, potentially incorporating a more robust study design alongside human factors analysis to better understand implementation outcomes, workflow integration, and that real-world behavioral change. In addition, these findings support the value of complementing didactic e-learning with applied, hands-on training approaches to further strengthen clinical skill development through those applied case scenarios. Collectively, these outcomes indicate measurable impact on provider confidence, perceived preparedness, and intended practice change, while also identifying clear opportunities for further evaluation and program development. I think the key takeaway for these modules is that they are demonstrating measurable impact on provider confidence, preparedness, and intended behavioral change. And this indicates strong potential to improve patient outcomes in the DV context. I think it also illustrates that a voluntary module is meeting the needs of the learner to safely inquire about domestic violence. So despite demonstrating strong educational outcomes, there are still several systemic level barriers that continue to affect our sustainability and consistency of program implementation. And these barriers include the following. So we are under a short-term funding cycle. So the DART program is currently supported through a short-term government grant funding contracts, which is scheduled to conclude in December of 2026. So this creates uncertainty regarding long-term sustainability. As everyone is aware, there is huge staff turnover in healthcare. Since COVID-19 pandemic, healthcare organizations have experienced increased workforce attrition. And so as a result, there are a greater proportion of clinical staff that might be limited in experience and training related to domestic violence identification and response. As everybody also knows, we have gone through an organizational restructuring. So since 2023, Alberta Health Services has undergone that significant structural reorganization. The former integrated healthcare system has transitioned into 4 distinctive service pillars. This includes Recovery Alberta, of which I am under, Acute Care Alberta, Primary Care Alberta, and Continuing Care Alberta. And this restructuring has introduced additional complexity in maintaining consistent educational practices across the system. And then finally, there is a lack of mandatory training requirements. So although domestic violence education modules remain available and accessible across all 3 pillars, there is currently no organizational policies or mandatory requirements governing their completion. When we think about this collectively, these factors contribute to variability in clinical preparedness and the readiness to respond to domestic violence. And within this context, education then serves as that critical stabilizing infrastructure. It promotes continuity, supports workforce capacity, and it helps mitigate the effects of fragmentation with an ever-evolving healthcare system. So what's the interim solution to these system-level challenges? Well, it's really about shifting from a reactive approach to a proactive approach. This is where we build educational modules that are designed to last. They're accessible 24/7 for healthcare providers. They continue to function through organizational change, and they provide consistent training regardless of staff changes or who is available at any given time for a consultation. For our partners who continue to collaborate with us and need support in delivering domestic violence education, these modules can be used flexibly within their own departments. And again, it doesn't matter if there's turnover or system restructuring, they remain available and usable in whatever way best fits the context. In doing this, we shift from a system that is consistently reacting to disruption to one that has the infrastructure and education in place to support early identification, intervention, and ongoing care for patients experiencing domestic violence, and to support the healthcare provider who needs that consistent education and support. So now returning to the earlier discussion of why domestic violence is addressed as a healthcare intervention, it's important to consider again the clinical and health system context. Domestic violence is both prevalent and frequently under-recognized in healthcare practice. Healthcare settings are among the primary points of contact for individuals experiencing violence and are often the first environments in which early indicators may be identified. Unlike many other sectors, healthcare providers' ongoing, non-conditional access to care created repeating opportunities for recognition, assessment, and intervention. Within this context, education then transforms routine clinical encounters into opportunities for effective intervention. It equips healthcare providers to recognize indicators of domestic violence, respond appropriately to disclosures, and deliver care that prioritizes safety, consistency, and patient-centered practice. More importantly, the purpose of education extends way far beyond acquisition of knowledge. It is intended to build clinical competence and strengthen the health system's capacity so that regardless of whether a patient discloses abuse, providers feel prepared to recognize potential indicators and respond in a timely informed and trauma and violence informed manner. Education therefore serves as a foundational component of the healthcare response to domestic violence, supporting both individual clinical practice and the broader capacity of the health system to identify and respond to violence effectively. This expectation, I want to point out, is also important to within our professional regulations. So regulatory colleges require healthcare providers to identify their own learning needs and acquire the knowledge and competencies necessary to practice safely and effectively within their scope of practice. So as domestic violence is increasingly recognized as a significant health issue, developing competence in its identification and response truly aligns within these professional obligations. So now building on the development of the domestic violence electronic learning modules, the next phase I want to talk about is the focus on expanding access beyond our healthcare settings. So through a series of engagement sessions with multidisciplinary stakeholders, the training was brought in to include professionals in community services, law enforcement, and social work. This expansion recognizes that individuals experiencing domestic violence often interact with multiple systems rather than a single point of care. So to better support a coordinated cross-sector response, the DART team sought to make it educationally available to diverse professionals who may encounter and support individuals affected by domestic violence. So by making these modules externally accessible now, the foundational content is no longer limited to just healthcare providers alone. Instead, it provides a shared baseline of knowledge that can be applied across different professional contexts. And this approach really supports the adaptation of core principles related to identification, screening, and response across varied settings. While the implementation may be different depending on the environment, the underlying clinical and practice principles remain consistent. And such consistency is critical in reducing fragmentation across our systems of care. It contributes to more coordinated responses and helps ensure that individuals experiencing continuity rather than variability in support depending on where they disclose. So we're ensuring that we reach the individual no matter where they disclose domestic violence. Ultimately, this shared approach strengthens intersectorial collaboration by aligning providers across systems with common frameworks for responding to domestic violence. So as of January 2026, we've worked with our communications and web teams to host our introductory domestic violence module on our addictions and mental health website. This is a public-facing website that allows external organizations to access the modules without requiring specialized login, as we would for the My Learning Link or Click platforms. In terms of feedback, we still have REDCap surveys that are automatically triggered when there's a completion of the module on the external site, and we're continuing to receive and review that incoming data. So what's next for the last half of the grant contract that ends in December of this year? Well, we are building on the success of the 2024 and 2025 education grant that supported the initial development and implementation of these domestic violence electronic learning modules. And this is a program that is expanded through subsequent commission to develop now a sexual violence module that aligns with the domestic violence modules we've completed. This expansion reflects the growing recognition that healthcare providers still require education across the broader continuum of gender-based and interpersonal violence. While domestic violence may include sexual violence also occurs in many other contexts, underscoring the need for dedicated education to strengthen provider knowledge, assessment, and response. During the first 2 quarters of this initiative, work has really focused on that foundational development piece, including stakeholder development engagement, environmental scans, and our literature reviews of current evidence to assure alignment with clinical practice, system priorities, and long-term sustainability. This has included a unique opportunity to also collaborate with law enforcement and our domestic violence conflict teams to support a more integrated understanding of not just the survivor pathway across the system, but across the justice system. I want to point out here that there's a very significant milestone within this work that was approved to include a lived experience patient story. This includes video testimony of the patient highlighting both the system gaps and moments of meaningful care. The narrative itself provided a powerful learning opportunity for healthcare providers, reinforcing the importance of appropriate screening, assessment, and intervention in supporting survivors of domestic and sexual violence. A key outcome for this work has been the development of a sustainable module framework that is designed to support not only current sexual violence module, but also future violence-informed education. This is a scalable approach that promotes consistency in content development, deliverability, and evaluation across future educational initiatives. And so finally, from a planning perspective, the project is structured across 3 phases. The first phase, which has occurred now between February and March of this year, focused on our feedback collection and contextual research. The stage ensures that the module is informed by both the end user experience and current evidence, as well as by system-level needs identified through prior implementation of our domestic violence modules. In the second phase, which we're in right now, is happening from April through to our late summer, and this has involved e-learning development. So that includes things like content creation, instructional design, and integration of the established digital learning environment itself. And there's a whole planned launch within fall of 2026 this year. So this brings us to the final phase, which will happen from fall through to December 2026. We'll focus on the launch and the evaluation of the module, and this will include our learner feedback, our data collection and analysis of the uptake and impact. And the purpose of this phase is not only to assess effectiveness, but also to inform that iterative improvement piece and guide further expansion of the program education itself. So when we take this together, this initiative represents a continuation of the broader shift towards embedding structured, scalable, and evidence-informed violence education within our healthcare system. So I want to thank you for your time and the opportunity again to present. Should you have any questions or require further information about our program, please feel free to contact our team at dart@recoveryalberta.ca, which I've left on the screen here. But I really hope from this presentation you can see that as healthcare providers, we're deeply passionate and committed to this important work. And in our DART team, we are confident that these education continues to support our healthcare providers in improving those outcomes for those who are at risk or affected by domestic violence. So thank you again.
Thank you so much, Nikki. Such a powerful presentation, such an important initiative. The Q&A is open, and while we wait to see if people have questions, I do have a couple of questions for you, if that's all right.
Sure. Would you like me to stop sharing my screen or
Can you
what
leave
would you?
that up for a minute so people can take the survey?
Yeah,
Awesome.
absolutely.
Thank you so much. And yes, a good reminder for me, there is the QR code on the screen for the survey. So you have a lot of experience educating healthcare providers and working in this field. So I was wondering, what do you see as sort of the biggest challenge or the biggest challenges that still exist in preparing healthcare providers to recognize and respond to domestic violence?
So I'm going to approach that as a twofold question, Sarah.
Mhm.
So one of the
Perfect.
first things we noticed when we do our education sessions and gain our feedback is that they really feel underprepared. And they feel underprepared because they don't feel they have the knowledge to approach patients with what they're already working with. So I'll give you an example. A lot of the patients that we see, and especially in my experience, has always been through an emergency department. We try to medically stabilize patients first before we send them anywhere else. And there's good reason for that because a lot of our patients who have been in domestic violence situations or sexual violence situations, there are physical injuries, although they might not be present. We want to make sure we're doing our due diligence to make sure they're medically stable. And in doing that process, we need to have conversations with them and ask them some pretty tough questions sometimes. And so healthcare providers feel that they're going to do more harm by having these conversations because they don't feel equipped to have them. They feel competent to ask if they have heart palpitations and put on an ECG and check, physically what's going on. But when it comes to that psychological and social aspect, they're really struggling. The second piece to that, I would also say, is the accessibility. So, as I presented in the presentation, a lot of healthcare providers work shift work and they do multiple mandatory training requirements. And so, because this module itself is not mandatory, they really have to have that self drive to go and want to learn more about domestic violence. So, in that secondary piece is really talking about the fact that we want to be able to reach them wherever they are. And so, this is why we've built the modules the way we did, because we want them to be accessible. So, if you're at shift at 3 in the morning and it's quiet, I don't know a shift that's ever quiet at 3 in the morning, by the way. You can pop onto a computer because we have, movable computers now in the healthcare system, and they can go and they can do their training whenever they need. And so the feedback from that has been astronomical in the fact that it's so accessible that, yeah, they can come back or they can leave if there's something that they have to do for a patient, and then they can come back and look at, the training, and the training really leaves off where they left off. So again, we talk about that accessibility piece. So I hope that answers that question for you.
Absolutely, it does. And you've mentioned feedback. So I'm wondering, have you
Mhm.
received any feedback from healthcare providers or patients that has particularly stayed with you and influenced the direction of this program?
Yeah, absolutely. In the data that we've collected just from the self-reported surveys, one of the pieces that stays with me is 88% of these individuals are going to actually apply this into their clinical practice. That's huge because before it was just even getting them comfortable with having a conversation. But now they've taken these modules and they actually feel like they can use this in their clinical practice. And we weren't initially seeing that before. So I think for me, that's one of the things that stands out. I might even pop to Lindsay because she does do a lot of our data
Yeah,
collection. And
please.
I don't know if Lindsay maybe also has anything to add to that in terms of those feedback quotes.
Yeah, thanks, Nikki. I think one of the things that was really stood out just working with Nikki on this project and getting the feedback from other participants, a lot of it is just asking the question, how do I ask a patient who might be there for something else? Maybe they're there for a knee injury, or the explanation is that they fell off their bike, but the nurse is thinking, I don't know if this is really what's going on here, but I'm afraid to ask. And if I ask and the person says yes, then what? And I think that was really where Nicole brought in a lot of her expertise, is to help those healthcare providers know what to do when somebody says, actually, yes, I'm not safe at home. This injury is a result of, uh, a physical altercation with my partner. And then the person doesn't have to say, oh dear, this person's now said, yes, this is a issue and I'm not sure how to respond. They really have the confidence to go forward, help that patient with the medical pieces, as well as the next steps into getting help. And another important piece that I really love, and Nikki says it better than me, is sometimes it's about planting those little seeds, right? Maybe this is the fifth time that a patient has presented to the for an injury. And if all five times they were asked, a lot of people are experience these things in their relationships. Are you feeling safe at home? Um, those types of questions, maybe on that fifth time or 10th time or 12th time, if they've had that positive experience throughout those previous attendances at the clinic, then maybe one of those times they will feel comfortable enough to say, you know what, I do need help. So I think that's what really stuck with me from from the participants, is just knowing if somebody says yes, guess what? I know what to do. Um, yeah, Nikki, I hope that helps. And
That's perfect. Perfect, Lindsay. Thank you.
all right, yeah.
That's so great. And based on your presentation, this is such a thoughtful and well-structured, and I don't know, I've worked with a lot of online platforms. There doesn't seem to be nearly as much of a systematic way of how you do things, why you do things, and what your next steps are. So I'm curious for folks maybe in other provinces or other countries if they wanted to develop something similar. Do you have any like tips to get started? Like things you learned while you were doing it that maybe you wish you knew in advance?
That's a good question, Sarah. I think coming from a quality improvement background, program design, and really looking at, I would even say, workflow integration, human factors, those are the top things that I would say for programs going forward, they need to look at first. So, what do I mean by that? So, we talk about things like getting feedback initially from healthcare providers. So, creating a program or creating that education that supports that program development. And when we talk about that, we look at within that program what's already working, so a needs assessment, right? What are they providing, what's working from that providing, because I think today we focus so much on what's not working. We need to start with what is working, solutions based, and then move into, okay, where are those gaps? And so that's exactly what we did with this program. And it wasn't until we came into those gaps and those challenges that we're like, oh, that's what we need to do, that's how we need to integrate this information. So as much as I can say, programs you can take from something and copy it, there's something to be said about making those mistakes and seeing what those challenges and barriers are, because that I really think brings into play what you can do to better the program down the road. So I guess the answer to that question really is looking at what's working within that program. Where are the gaps that you're finding through needs assessments? And then mapping that out, right? And looking at what that looks like mapped out in terms of that program specifically, because every program is going to be different. And that's one thing I will leave with is these modules. We really had to think about, there are over 67 or more departments provincially within healthcare, how are we going to hit them all with this education that is going to be applicable to all of them? And so it isn't really until you understand some of those departments, or like myself, you work in several different departments, that you understand those nuances and where you then can do a more generalized, high level overview of education, especially for things like domestic violence. I hope that answers the question as well.
Yeah, absolutely. And I saw, Lindsay, you took your mute off. Do you want to add something?
Uh, yeah, I thought another important factor for other, provinces or organizations to consider is sometimes a policy is put in place. Like, okay, let's start universally screening patients for domestic violence. And and sometimes those questions are built into the system. Every patient is asked. But I think what's important is if organizations are going to start implementing policies in that space, to really think about, the response piece. Um, and I always think that um, sometimes education programs are have one piece and not necessarily the second piece. They have the policy, but the healthcare providers need that support to know what to do and how to do it well. Um, and so I would suggest to other provinces is make sure both pieces are in place, or one doesn't come before the other, so that those healthcare providers, when something comes into policy or is a recommended practice, that they really know how to confidently implement it in their space.
So well said. Thank you, Lindsay. And I think that gets us through all of the questions. So thank you both so much for Nikki, a fabulous presentation, and both of you such thoughtful answers to the Q&A. On behalf of myself, I know our audience, and Ava as well, we so appreciate your time and your expertise in sharing that with us today.
Thank you so much, Sarah. Thanks for having us.
Our pleasure.